Hello, it's a pleasure to be participating in this educational program of IPITA. I was a co-founder of IPITA and a former president of IPITA, so it's truly a pleasure to participate to an educational program for the new and not so new generation of fellows and friends. My name is Camillo Ricordi. I'm a professor of surgery, chief of the Division of Cellular Transplantation and director of the Cell Transplant Center and Director Emeritus of the Diabetes Research Institute at the University of Miami, which I had the privilege to head for the past 3 decades. Let's see if this can go forward. So this is a little history of how we started islet transplantation and my experience that started in the 80s, when I used to look like in the upper left corner here. And when we developed the automated method for islet isolation at the Washington University in St. Louis. The rest of the history I will touch in this presentation and in a future one that will be on the future of islet transplantation. But for now, most of this presentation has been modified to what I originally presented as a Lilly lecture when I received the Outstanding Scientific Achievement Award of the American Diabetes Association in 2002, a lecture that was established in 1957, the year I was born, and was called Islet Transplantation, A Brave New World. So what we have to address is like, what is the challenge? We are all familiar with diabetes, but I want to just remember and remind our newest fellow that diabetes was actually first described by the Papyrus Ebers. That was the first description of passing too much urine. And this publication was found next to a mummy in the tomb of Thebes and could have been written between 3000 and 1500 BC. It was then sold to a German Egyptologist, George Moritz Ebers, in 1872. More recent time, 1 century AD, Eratosthenes coins diabetes as a term from the Greek siphon or pipe-like, indicating a melting down of the flesh and limbs into urine. Here you see a picture of the Papyrus Ebers on the right side. Transplantation in diabetes started in 1893, and I think if you have a chance to see this British Medical Journal 1894 was quite instructive, because these were notes of diabetes treated with extract and graft of a sheep's pancreas into a diabetic child that was in diabetic coma, very severe diabetes. The transplant didn't work, but Dr. Williams in the discussion was interested because he mentioned, since the transplanting of the pancreas failed, we shouldn't attribute too much importance to the pancreas in the treatment of diabetes. Those were the years in which it was still under discussion. There was a vivid discussion among scientists on whether the pancreas was producing a sugar-destroying substance. This was 2 decades before the discovery of insulin that would happen in 1921. But then it's interesting also that in 1929, Brancati performed the first duct-ligated pancreas modificator, where he put fragments, transplants in the omentum, and you will learn later why the omentum is becoming also important nowadays. But it was the first histologic demonstration of 1 month of preserved islets with acinar atrophy following transplantation of these fragments in the omentum. As you know, Banting and Best discovered insulin that was later purified by James Collip. So the 3, Banting, Best, and Collip, have been attributed the discovery and purification. And It's interesting to note that, as often happens, surgeons come up with crazy ideas that then eventually they're lucky enough to be able to test, because McLeod was initially very worried about Banting, as he has never worked in diabetes research before, but eventually granted him lab space at the University of Toronto to conduct his experiments with the help of his research assistant, Charles Best. So insulin was discovered in Toronto in 1921, and interestingly, John Fitzgerald of Connacht Laboratories, when saw the discovery of insulin, noticed that they needed support and offered the team the Connacht facilities and $5,000 to expedite the process of production. And on January 23rd, 1923, 1 century ago, Banting, Best, and Collip were awarded the American patents for insulin, which they sold to the University of Toronto for $1 each. Banting's famous quote was, "Insulin does not belong to me, it belongs to the world, and everyone who needs it should have access to it." So for sure, they didn't know what multi-billion profit business insulin would evolve eventually. But diabetes was changed forever by the discovery of insulin. These are the famous pictures of children before insulin was introduced and how they appeared after insulin was introduced, the same children. Amazing result, life-saving procedure. So the hypothesis started evolving that islets are better than insulin. As we know, insulin cannot always prevent the development of complication in diabetes that remains a disease with an associated accelerated aging and a predisposition to develop chronic complications that are worrisome for patients and their family, besides the acute complication like severe hypoglycemic episodes that can be life-threatening. So the hypothesis that islets are better than insulin is because islets make their own insulin, have a built-in glucose sensor, allow for perfectly timed insulin release, keep glucose level in the normal range, and can function for an entire lifetime if they're not destroyed by the immune system. So the islet isolation and transplantation goes back to the 1960s with Lacy that performed islet isolation and intraductal distension with Hanks without collagenase, and then minced the pancreas. Then in 1969, Lindahl purified islets by density gradient, and in 1972, Lacy performed islet isotransplantation in rats, demonstrating in vivo function. In 1981, Horoguchi and colleagues introduced the duct perfusion before isolation. So the translational research approach started from the human islet isolation. So the challenge was that the islets, as you know, are scattered in hundreds of thousands of microscopic microorgans throughout the pancreas. And but they have one advantage: they are not tied to the ductal system. Their secretion go in the bloodstream through the portal vein, first passage through the liver. So it is sort of a double organ in which the endocrine precious load is around 1 to 2% and is scattered throughout the organ. And this is like what has been the challenge for decades, to isolate islets, separate them from the pancreas, because without damaging them. So the concept of perfusing the pancreas with ductal perfusion of an enzyme blend, putting it in a chamber in a full immersion system and getting islets on the other side through a progressive disassembling of the organ, saving the islets from progressive digestion by cooling and dilution, was initially met with skepticism. And when I first was at San Raffaele Institute in Milan with Professor Guido Pozza and Valerio Di Carlo, the head of surgery, and this is the team at the time, you may recognize some leaders in the field like Carlo Socci, Federico Bertuzzi, Paola Maffi, Simona Braghi, and others, and me with Professor Pozza. It was impossible to develop the system in Milan because I was given a little corner in the pathology department where they were performing autopsies, but we didn't have reagents, we didn't have a budget. I was told just wait midnight, go to the central laboratory and steal the solution that you need with a cart covered by drape, and then go do your work back in the anatomy pathology section of the institute. So that was not very efficient, but luckily I was able to convince Professor Pollesi, they're the leader in islet transplantation at Washington University in St. Louis, to accept me as a fellow. I became an NIH trainee, and it was quite instructive that for 1 year I couldn't test the system in a human pancreas because everybody was laughing at me, including engineers from McDonnell Douglas and other fellows, senior fellows in the lab, saying, how can you think that you can put a pancreas in a chamber and get islets on the other side? Don't you know that all the methods that are used so far are very mechanical? You need like meat grinders passing through needles of progressive decrease in diameters, or using Velcro strips, all very rather traumatic procedures that remember a little how insulin was first purified. This kind of meat grinder instrument was actually what was still used with modification, of course, at Washington University when I arrived in the 80s. So the concept to isolate islets from the pancreas with the automated method started in early 86. And initially, I was able to test it in the pig pancreas. That is a very delicate situation for islet isolation because the islets are very fragile and they don't have a pseudocapsule. They easily fragment and you have to be very careful. So after it was actually first used in pig pancreas, and later on was developed the human method with the automated method for islet isolation that was published in Diabetes in '88. It was of interest that I had to wait for a pancreas, human pancreas, to be discarded because it was a Friday night and arrived with a lot of cold ischemia, and nobody wanted to stay late wasting enzymes and reagents because the probability of success was very low. So I waited for the entire team to go home, and I pick up the pancreas from the trash, from the biohazard bin, and stay up all night to try the system, saying if it doesn't work, I will not say anything to anyone. And if it works, as it did, I called Leslie the next morning and I told him, you have to come see. And when he came to see the microscope at the islets, I saw his face expression and his color turning red and purple, and I knew that we were up to something that was unprecedented at Washington University. And within weeks, we replaced completely the previous technology. Here you see an image of the pancreas when it's dissected from the duodenum and then cannulated. The duct gets cannulated. And then you continue this disassembling process, maintaining the pancreas in the lower portion of the chamber, where a screen retains the fragments that are still too big. And when they reach the size of an islet, the flow can push the islets through and save them by dilution and cooling, as I mentioned before. Until at the end, what is left in the chamber is just a network of ducts, and the whole parenchyma is disassembled, digested, and saved. The final step is a purification step. At the beginning, we were using large conical tubes, like 250 milliliters tube in a centrifuge, and then the COB2991 cell processor was introduced, and we started automating also the purification step. We started doing transplants also of islets that were not perfectly purified, the so-called mantle islets. This was when I was at the University of Pittsburgh, but was interesting that the actual first successful islet transplant in 1990 was performed using this kind of islets. And we were worried, and there was a discussion whether we should have attempted or the transplant or call it a failure and discard the islet product. And luckily we did, because you can indeed transplant mantle islets with excellent success, as that patient became insulin dependent and was the first case of insulin dependence in an islet allograft in 1990. We then started exploring also islet isolation from all kinds of age pancreas, pediatric age donors and neonatal donors. And was interesting that in this setting, you barely need any purification, because almost every cluster of pancreatic tissue contains human islets. This system has been evolving and perfected and improved through collaborative efforts. I gave up the rights of the patent to share the technology worldwide for free, and this probably was one of the elements that helped many outstanding investigators to contribute to the further development of the automated method and what then was called Ricordi chamber. You may recognize here, besides Paul Lacey, Bernard Herring, Ray Rajot, Jonathan Leckie, James Shapiro of the Edmonton Protocol, and Carlo Socci and Federico Bertuzzi. Socci actually was the first one who tried the automated method in mouse islets and was part of his medical degree thesis in Milan. Here is David Harlan, Rodolfo Alejandro, pillars of the Miami Diabetes Research Institute, and here David Sharp and Norma Knetman in St. Louis with Barbara Olak. And here you can see Paul Lacey behind the first patient transplanted in St. Louis with a younger me here to the right. And Paul Lacey, you may not notice, but he was lighting the pipe, his pipe, because in those days was allowed to smoke in the operating room. And here is Paul Lacey with Daniel Mintz, who was the scientific director of the Diabetes Research Institute before my recruitment at the University of Miami. So the proof of function after islet isolation in animal models, the first preclinical model system, we had to show islet function in animals. And we developed the system of transplantation of human islets in nude mice that don't reject human tissue. It's an immune-incompetent model system. And it was interesting that we were able to reverse diabetes following transplantation of human islets, both fresh, culture, or cryopreserved. And when I presented the poster at the American Diabetes Association, I had to ask Paul Lacey, can I present this poster, submit this abstract? And he said, I cannot submit any more abstract because I already have 3. That was the maximum number submitted by an individual investigator, but go ahead and submit it with just your name. And of course, I was all excited. I prepared months to prepare this poster, and then I arrived at the ADA conference with the first reversal of diabetes with human islets purified, and nobody stopped by my poster because there was no name that was recognized. So it was quite an experience, and I never spent that much time on a poster again in my life later on. But anyway, these were fundamental data because show that human islet isolated and purified with this method can function, can reverse diabetes in mice, either fresh, culture, or cryopreserved and thawed. And you could demonstrate a reversal of diabetes and then remove the kidney bearing the graft. These were renal subcapsular transplants, and then you can stain the transplant with glucagon, insulin, somatostatin to identify and study the integrity of the transplanted islets. Then a big effort was for islet isolation assessment in those years, because suddenly there were groups left and right claiming improved method of islet isolation, because now they could isolate instead of 300,000 or 400,000 islets, 600,000 islets. But actually what it turned out that if you shake a tube with islets, you can double the number of islets, just decreasing the average diameter. So one of these important element that was introduced is the so-called islet equivalent that is still used in islet isolation laboratory worldwide. That is a way to standardize islet results by the average islet size of a so-called equivalent islet, that is an islet with a diameter of 150 micron. There were many other elements of islet isolation assessment, but this was the first agreement in international meeting between all the leading laboratories worldwide about how to standardize and assess islet isolation. Then the proof of function in human was initially, we had a paper in St. Louis that was published in Diabetes in 1990. Was done actually in 1989, December, and this had a few days of insulin independence, but unfortunately the transplant failed immediately after this early period and was rejected. So it was a big disappointment among the team and everyone who knew about the failure of that initial transplant. The actual first successful long-term islet transplant in an allograft were performed when I moved to the University of Pittsburgh in December 1989, and with the Christmas holiday in between, we were able to start the first transplant on January 10, 1990, the first of a series that was later published in The Lancet a few months later, showing in the surgical model of diabetes following pancreatectomy as part of this upper abdominal exenteration for advanced malignancies, where the liver was transplanted and islets from the same donor were infused into the liver, producing a dramatic effect and insulin independence with sustained C-peptide production. That was the time where we started the Cell Transplant Society, now Cell Transplant Regenerative Medicine Society, with Thomas Starzel. It was covered and reviewed by Science, the first Congress of the Cell Transplant Society that was done in Pittsburgh. And the rest is history, but the number of islet transplant attempts improved dramatically since the introduction of the automated method. And soon Milan performed the first successful transplant in a type 1 diabetic subjects with Carlo Socci in Guido Pozza's team. Then Edmonton followed with Warnock and Rajot, and Miami with Alejandro and Mintz, and St. Louis with Sharp and Leslie, and Minneapolis with Paul Gors and Sutherland. We also had the first demonstration of islets in the liver, in liver biopsies post-transplant. That was very exciting to see integrity of the islets following intrahepatic transplantation. And the challenge was then to prevent rejection and recurrence of autoimmunity following transplantation. The initial results were quite disappointing for long-term results, even if kidney islet transplant combined, liver islet transplant combined, or cluster islets show already the challenge when we started doing kidney islets in type 1 diabetes. Initially was because since islet transplantation was working just with FK Prograf monotherapy, Dr. Starzel wanted to do the same also in autoimmune diabetes, and that clearly was not the way to go. In the meantime, the experience in autotransplantation following pancreatectomy for intractable pain following chronic relapsing pancreatitis also benefited by the introduction of the automated method, as the number of islets recovered correlated with the dispersion method, and was published in the Annals of Surgery in 1995 that the number of islets transplanted was the main predictor of insulin independence at over 2 years in islet autotransplantation. So besides allowing and enabling islet allotransplantation, there was a contribution of the technology also to islet autograft. Long-term function, 6 years of islet allografts, was published by Dr. Alejandro with me and Norma Kenyon and the rest of the team in Miami. By the time I moved to Miami in 1993, this was 1997, we work also on improving islet isolation using new enzyme blend, the famous Liberase by Roche, that was much more purified with less endotoxin contamination compared to crude preparation. And indeed, we demonstrated when Thierry Berny was a fellow in our lab before becoming the famous Thierry Berny head master and commander of University of Geneva and European Organ Transplant Society, and many others, show clearly how endotoxin mediated the delayed islet graft function and is associated with increased intra-islet cytokine production and islet cell apoptosis. In those years, the Gissen group, headed by Bernard Hering, started showing the first results of improved islet transplant by using combination strategy, not a single immunosuppressive agent, being careful both to immunosuppression with combination of agents and anti-inflammatory peritransplant treatment, but was the Edmonton trial that clearly set up the pace and became the standard, with James Shapiro and collaborators dramatically improved the results with 1 year insulin dependence over 80%. And this was done while we were trying to induce tolerance with single donor pancreas. James Shapiro and collaborators started putting islets from multiple donors, 2 donors up to 4 donor pancreas, showing that if you have enough number of islets and if you have this like steroid-free immunosuppression that was with a combination of sirolimus, tacrolimus, daclizumab, and no steroids, incidentally was similar to also in Pittsburgh in the allograft series was a steroid-free protocol, but only with tacrolimus, which was not effective in autoimmune diabetes. Here you see Jonathan Leckie with James Shapiro shaking the Ricordi chamber before the automated shaking device was developed. And the problem of immunosuppression began to emerge from requirement for statin therapy with ulcers, renal dysfunction, pneumonia, and others. And despite that, you'll see in the future how 20 years patient survival is actually better than with insulin without immunosuppression. So after Edmonton, we started looking at the relevance of pre-transplant culture, because when we did the multi-center trial of the Edmonton protocol, we noticed that of the several centers included, the success rate varied from 100% in a couple of centers to 0% with everything in between. And this is because of the so-called primary non-function. So what we introduce is the pre-transplant culture to allow for assessment of the early preparation before they're infusing the patient, to make sure that they have functional integrity, viability, and that they will yield a biologic function post-transplantation. So this was an important introduction of this safety net, and we started in Miami this trial with islet isolation and assessment pre-transplant. Insulin requirement were dramatically improved after the first transplant, and insulin dependence was achieved after the second transplant, similarly to the Edmonton protocol, with outstanding, very good glucose control and glycemic variability. So since then, many centers, Edmonton, Miami, Minneapolis, Houston, Geneva, Zurich, Milan, Philadelphia, and NIH perform successful islet allotransplantation. And from then, the field has dramatically evolved, but the problem emerged that the immunosuppression we were using was diabetogenic. It could induce diabetes even in patients without diabetes to begin with in renal transplant. So it was shown that steroid for sure accelerate chronic failure also of intrahepatic autograft, where you don't need immunosuppression, but we show that if you add prednisone, you can have accelerated failure of these grafts. We show the deleterious effect of Prograf of FK506 on human pancreatic islets in 1991. And this effect was reversible when Prograf was discontinued. And the diabetogenicity of calcineurin inhibitor in steroid-free protocols was also reported later on, linked to insulin resistance, the reduction of beta cell secretory reserve. And practically, the immunosuppression use was imposing a metabolic demand on the transplanted islets that was 2.5 higher than in an autograft transplant setting without immunosuppression. And that is why you need so much less islets in an autograft. A major development was the introduction of anti-CD154, anti-CD40 ligand in islet transplantation, something that hopefully is starting very soon now with the Eledon trial that reintroduced anti-CD40 ligand. Norma Kenyon and our team was able to show success in non-human primate with remarkable results showing how this was able to produce a threefold increase in insulin secretion from the transplanted islets compared to when you were using Prograf-based immunosuppression. So immune tolerance became a major focus, because if we want islet transplantation to become a practice for all patients with insulin-requiring diabetes, not just type 1, we need to prevent the need for chronic recipient immunosuppression. We have historically Peter Medawar, as you know, won the Nobel Prize for tolerance induction in mice. Anthony Monaco also did incredible studies in this direction. We work with Starzl in Pittsburgh and Susan Ilstad and others on the concept of inducing donor-specific tolerance to avoid recipient immunosuppression through bone marrow transplantation, showing donor dendritic cells that repopulated tolerant recipients and were ubiquitous and was thought to play a key role in the process of tolerance induction, these antigen-presenting cells. This was published in those years in Transplantation Science, and donor bone marrow infusion for chimerism started becoming a very interesting strategy. Unfortunately, was also associated with increased risk of graft versus host disease as you try to push the chimerism level in the recipients. This was done in liver transplant recipients mainly. So these are several papers in those years on bone marrow transplantation and mixed allogenic chimerism to induce tolerance and reverse autoimmunity. And this was also the base of several key publications discussing the potential to induce tolerance when a bone marrow transplant is performed. And this traffic of cells of bone marrow origin was showed also when you transplant organs like the liver that has a higher content and is also associated with a higher probability to induce tolerance. These are some of these papers, and co-stimulatory blockade, as I mentioned, with Norma Kenyon, the anti-CD40 ligand, was a fantastic development because it showed that if you can block signal 2 after the initial recognition of an antigen, if you don't have this co-stimulatory signal, the immune system thinks that it's self and follows with a tolerance accepting the graft. So we started using anti-CD40 ligand. That was then called CD154, and it has also an effect on decreasing cytokine. It has an anti-inflammatory effect and was really a fantastic drug, with the exception that in clinical trials in kidney transplant, that unlike islet transplant, they don't use heparin, because when you put islets in the liver, you put heparin in the transplant solution. They observed thromboembolic events that lead Biogen IDEC to remove anti-CD40 ligand from the market. And now it passed 2 decades to now to see again anti-CD40 ligand reintroduced after re-engineering the crippling Fc receptor of the antibody to avoid this thromboembolic risk. This is Norma Kenyon, that was the lead author in this paper, published in Proceeding of the National Academy of Science in 1999, and many other papers showing dramatic metabolic control of insulin in non-human primates. And this is a series of papers confirming the initial observation using this co-stimulatory blockade. This importantly led to the creation of the immune tolerance network by NIH that followed the results with anti-CD40 ligand, because suddenly it was thought that tolerance induction is an achievable goal, mission possible. So this was a very big step for NIH. And at the end, we also realized that the second challenge is if you can prevent rejection without using immunosuppressive drugs, then the next challenge is how do you have enough islets to transplant everyone? Because at that point, everyone will want an islet transplant. And we don't have time to go into the detail of all the different approach to provide islets from unlimited sources, but I can just mention in those years, pigs started becoming more explored, combined with immunoisolation technology to try to introduce barrier technology, semi-permeable barrier to protect the islets from the immune attack while allowing the diffusion of insulin response to glucose, and procedures that are still being improved nowadays, from Alice Tomei to the Vertex trial, to from very small capsule, like conformal capsule, to macro devices, and hopefully we'll see better results also in clinical trials. Elena Edlund, pioneering our Institute Stem Cell and Pancreas Development Programs, now head by Juan Dominguez Bendala, working also on pancreatic regeneration of beta cells from ductal elements. And I'd like to conclude thanking my mentors that make my research and progress possible, from Professor Pozza, who believe in me and allow me to go to Washington University in St. Louis, where Paul Lacey allow me to test the automated method after 1 year of various other research projects. Thomas Starzel, who recruited me to Pittsburgh to perform the first series of successful islet allotransplant, and Daniel Mintz, who successfully stole me from the University of Pittsburgh to come to Miami to head the Diabetes Institute that I proudly directed for the past 3 decades. And I thank my original co-directors and deputy director of the DRI, Dr. Luca Inverardi, Norma Kenyon, Rodolfo Alejandro. Norma and Rodolfo are still pillars in our institute, still now, and very productive. And I thank all the huge amount of collaborators of those initial days at the DRI and internationally, especially James Shapiro, Jonathan Leckie, Bernard Herring, but many others. And I thank, of course, all the funding agencies that allow our work to progress, and the Poe family that produce all the equipment, now called Bioret Biotechnology, still producing amazing equipment for islet isolation and beyond. AFL-CIO, now NABTO, the North American Building Trades Unions, that is one of our major supporters, together with the Diabetes Research Institute Foundation, where Robert Perman was the president in those decades, and the Stacy Joy Goodman Foundation, who allowed me the privilege to carry the Stacy Joy Goodman chair for all these years. So I thank you all, and I leave you with the last slide of my Lilly lecture in 2002 that depicted my little girls helping me in an islet isolation. Now they are over 30 years of age, and here are with my son Carlo, carrying him out of the hospital when he was born. So now it's up to you, new generation, to cross the finish line with the next quantum leaps in tolerance induction and stem cell or pig islet unlimited sources of beta cells and insulin producing cells. Thank you for your attention.